Join us this evening as we host one of our viewers' favorite shows, Ask Anything. Tonight's show focuses on all medical topics affecting those in our viewing audience. Ask Anything tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth. Prairie Doc knows that having access to trusted health information and education is crucial for promoting overall well-being and preventive care within communities. Each week, we provide our viewers with knowledge about disease prevention, healthy lifestyle choices, and promote that early detection of illness can lead to better health outcomes and decreased healthcare costs. We know that communities with access to trusted health information are more likely to engage in regular screenings and checkups, leading to early intervention and treatment for health conditions. Tonight, we will host one of our viewers' favorite shows, Ask Anything, and take any question about any topic. We've got some experts here. They're perfect for it. This evening, we are joined in the studio by Dr. Carl Rasmussen from Sanford, 49th and Oxbow Family Medicine in Sioux Falls, South Dakota, and Dr. Jennifer Tinguely from Falls Community Health in Sioux Falls, South Dakota, and also currently the president of the South Dakota State Medical Association. Welcome, and thank you both for joining us this evening. Dr. Rasmussen, if you don't mind telling us a little bit about yourself.
Yeah, my name's Carl Rasmussen. I grew up in Sisseton, went to Augustana for undergrad and USD for medical school, and was gone for a while, and happy to be back in South Dakota working here again.
Good.
Yeah.
Great having you.
Yeah.
And so then you did, after residency in family medicine, you did sports medicine.
Yeah, so I did a family medicine residency and then did a primary care sports medicine fellowship, and that's part of my practice now. I split my clinical time between family medicine clinic for Sanford and then an orthopedic practice.
And what does that entail? What do you see?
Yeah, I see any sort of non-operative musculoskeletal or orthopedic condition, and so we see just a wide range of conditions, all ages, and a lot of it's an extension of my primary care practice.
Excellent. Well, thanks again for coming on the show with
Yeah.
me. Dr. Tinguely, how about yourself?
Yeah. Yep, Jen Tinguely. I'm from Sioux Falls. I also am family practice. I trained med school, USD down in Vermilion, and then I was at the Center for Family Medicine in Sioux Falls. So a little bit of a non-traditional route to get there, though. I had done a master's degree in public health first, kind of out of college. Did that in Boston, worked for a number of years while my husband went to school, and we were in New York City. So I was working there and then came back and did med school. And yeah, I work at Falls Community Health. We're a federally qualified community health center. So we are considered a safety net provider in Sioux Falls. So we would see patients whether they have insurance or not. And so about 50% of all of our patients don't have insurance. We also do all of our new refugee intake for the city of Sioux Falls. So on average, we see about 400 new citizens to Sioux Falls, and we get to do all of their shots and blood work, their physical, and then hopefully can kind of keep them in our clinic and make that their medical home.
Well, what a great thing for the community to have that clinic there for people in a safety net, really.
Yep.
So we've got 3 South Dakotans that went away for a little while and then came back, and here we are.
Yeah.
Excellent. And as family docs, we're ready to tackle on anything, right?
That's right. Yeah.
Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion. Viewers can contact us in 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous, and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So, Dr. Carl Rasmussen, you did a sports med fellowship after your family medicine residency program, and in my practice, a common concern is shoulder pain. You know, it keeps them from reaching up high, and it's been there for a long time, hurts more at night. What are some of the things that might be going on there?
Yeah, depends on the age of the patient, you know, so that dictates a little bit about what we're thinking as a possible cause. Depends on, is this from an acute injury or not? But let's say it's a chronic shoulder problem. Let's say it's an older patient. We're thinking about things like rotator cuff tendinitis, and if tendinitis persists over time, it can become a chronic condition. We're thinking about arthritis of the shoulder. Could be of the ball and socket joint itself, could be of what we call the AC joint, which is a small joint that sits above that ball and socket joint. Those are three common conditions. We always want to make sure we're not missing something that could be nerve related coming from the neck. There can be overlap in symptoms there. So that's kind of a general way we would approach it for an adult with a chronic problem of the shoulder.
And so maybe you're doing some tests, you're thinking it might be rotator cuff, maybe you did an x-ray and arthritis isn't so bad. What do you recommend?
Yeah, I'm a huge proponent of physical therapy. And so oftentimes there's some muscular deficits in terms of some groups maybe not being as strong as we need them to be. For rotator cuff tendinitis, it's often kind of upper backside of the shoulder muscles that are involved in posture. So many jobs these days we're kind of over a keyboard, hunched in, and so we need to retrain muscles to kind of get our shoulders back, to really support our shoulders and our posture, and physical therapy is a great way to learn how to do that.
Absolutely. So important, and of course, we're probably going to need to do physical therapy before we can even get an MRI or anything else approved from insurance anyway.
That's true. So, that's often a game we have to play. But in the case of a rotator cuff tendinitis, where we're not worried about acute damage to the rotator cuff or something worse, it's a great place to start.
Exactly.
Yep.
We've got some great questions coming in already. And since we've seen a lot of cold and flu and norovirus lately, there was a question here from Facebook. It seems like every one of my child's friends had the flu right now. My child is achy and has a few coughs at night, but no fever or congestion. What are the symptoms you are seeing right now with the flu? Can you have the flu without having a fever? Jen, if you could help us with that one.
Yeah, I think, one thing that confuses people is when we think of the flu, I think sometimes people think the stomach flu. I've been throwing up, I'm having diarrhea. But when we talk about the stomach flu, there's actually a bug going around right now that people have probably been hearing about, is a norovirus. And that is a pretty fast acting, it kind of comes on really fast, lasts for maybe 24 or 36 hours, but it is not pleasant. Incredibly contagious, and so it's been running through households and daycares and nursing homes, schools. So that, people might call that the flu. I had the flu, but that was probably just a really wicked bug that is going to move through and be done. Influenza, on the other hand, much more serious illness. It is a viral illness, and there are some classic symptoms that come with that. Headache being one of them, body aches. People usually do have fever with influenza. Of course, there's always the one-offs where it's like, I haven't had a fever at all, and yep, you have influenza. This is also a contagious, illness that people can contract. The nice thing about influenza is there's vaccines that can help prevent the catching of it, or perhaps lessen the severity of those symptoms. So, as primary care docs, I think we're always talking about vaccines and the importance of getting your flu shot, kind of in the fall, winter. It's never too late. You can still get your flu shot now. We are really starting to see a spike in the number of cases of diagnosed influenza. So get your flu shot.
Absolutely.
So we keep telling my patients, if you haven't had it, get it. Yeah.
Absolutely. And I'd add, for those that are higher risk or older,
Absolutely.
have more chronic medical conditions,
Yep.
The flu comes on quickly.
Yep.
And and then you have the chance to come in and maybe get a treatment for
Yes.
that. What is the medication for that, Carl?
Yeah, Tamiflu. And so I think if you do have onset of symptoms where you're worried that this could be the flu, or it could be COVID, another one that's contagious and very contagious, and we're still seeing a lot of. If you think you might fall in one of those higher risk categories, whether it's age, whether it's a chronic medical condition, it can be important to come in, get tested, so that you know what your options are. Because if you do test positive, there are antiviral treatments out there, both for influenza and for COVID, that we can use to shorten the duration, shorten the severity of the illness.
Yeah, but they work best, especially for influenza, within the first 48 hours
Yeah.
of symptoms. So that's why it's important to come in.
Yeah.
Yep.
Yeah.
And we're starting to see if that long COVID syndrome that people have been dealing with if they've had a COVID infection, there is some evidence to show that taking that antiviral medication can perhaps alleviate some of those long-term effects that we're seeing from COVID. So I completely agree. If you're a high-risk patient, whether it's age or you're diabetic or you have COPD or asthma, make sure that you get in quicker, sooner rather than later, so that you do have an option. Yeah.
But if you're younger than
Right.
60, 65 or so, or and healthy, you probably can
Get
what would
by
you
without
recommend?
it. Yeah. I mean, it's sometimes nice to still get tested, because then if I have influenza, probably don't want to go visit my 85-year-old grandma. But do I need to take the medication, that antiviral? No, probably not.
But I don't need to be going to work and getting everyone else sick.
That's right.
Exactly.
Or,
You should still follow very good, post-infectious guidelines of don't go to work if you've had a fever, if you're coughing everywhere. Certainly if you're vomiting or having diarrhea, don't go to work, don't go to school.
Yeah.
We're trying to slow down the spread.
Exactly.
Yeah.
Exactly. This question asks from an email, this person asks, I've been struggling with neck and shoulder pain and stiffness with headaches for the past 6 months. I've tried multiple chiropractors, massage, and acupuncture. A few years ago, I did PT for chronic neck pain and headaches. Should I be concerned that there's something else causing this rather than just muscle tightness? Next steps. What would you say to them, Carl?
Yeah, I mean, a good kind of continuation of what we were chatting about earlier with shoulder pain. Like we were talking about, shoulder pain and neck pain, there can be overlap. You can have both at the same time, but sorting through maybe what's driving what can be a little tricky. So would definitely encourage this patient to consider seeing their primary care doctor as a first step. Perhaps some imaging might be warranted, either of the neck or the shoulder or both. And yeah, depending on what their exam shows, kind of, their range of motion, their strength of the shoulder, we might be going back to talking about physical therapy, and if they did it a few years ago and had a good experience, this, very well could be a situation where it might be beneficial again. But again, starting with your primary care doc, a good place to start for this.
But those neck muscles and tension can cause headaches and
yes, definitely. Tension headaches, the most common type of headache that we see. And so both shoulder and neck muscle tension, anywhere in that region can bring on a tension headache.
Jen, from this person that sent in a question from email, is it safe for a woman who has had a stroke to use Mirena for heavy bleeding during perimenopause? Does the Mirena cause weight gain? Let's back up and talk about Mirena first. And then, but if someone's had a stroke or if they're worried about weight gain, what would you say to them?
Yeah, I mean, I do think we have to be more cautious if somebody is wanting to have some sort of birth control method, and that may be for heavy bleeding. It may not be for pregnancy prevention anymore, but the risks with any kind of hormonal contraceptive, whether it's pills or devices, you have to be cautious and look at the family history or if there's a personal history of stroke. But I would say that there are reasons for people to still be on a device like a Mirena or even a birth control pill. There's multiple reasons why somebody might need to be on that. But there are certain ones that are safer for somebody that's had a history of a stroke, or perhaps there's a clotting disorder that they have themselves or there's a family history of. Certainly that is a question to talk with your primary care provider about, to make sure that you're picking the safest device or the safest pill if you are dealing with heavy bleeding.
And a Mirena is an IUD,
it's
intrauterine
an IUD,
device, and I think is the use increasing again? Would you say?
Yeah, I would say that that's what we're seeing used more frequently, especially in women. Smokers, we have to be very cautious with birth control in smokers, and so the Mirena is a bit safer of an option, just given the type of hormone that is released from that device. So we are definitely seeing, I think, an increased use of that, but it is very effective for slowing down bleeding when women are dealing with something like that.
Very good. This caller asks from Madison, what causes pancreatitis and what are the common treatments? What would you say there, Carl?
Well, there are multiple causes. Alcohol is a primary cause. If somebody's triglyceride level, kind of a fraction of your cholesterol is really high, that can trigger pancreatitis. There are certain viral causes of pancreatitis. So there's a lot of different causes, but again, alcohol is a primary cause that we see. If that's, the symptoms of pancreatitis are epigastric pain, so kind of upper abdominal pain, generally quite severe. And so if a patient is concerned for pancreatitis, that's something that you want to have evaluated right away. And depending on how severe your symptoms are, it may be a trip to the emergency department. But again, if your symptoms are perhaps more on the early side, on the milder side, visiting your primary care doc is an okay place to start.
Yeah, and when that pancreas is getting inflamed and it looks like pancreatitis, what do we usually do for treatment?
Yeah, for treatment, I mean, a lot of times people do end up in the hospital, so I can't reiterate the importance of, if you think you could have something like pancreatitis, or certainly if you've had a history of pancreatitis and now you're having a recurrence of those symptoms, to be evaluated, because you're going to need lab work. You're likely going to need imaging, a CT scan of your abdomen and pelvis just to see what's going on in there. But treatment, often it's just rest, it's GI rest. You cannot eat, you can't drink, you might need some IV fluids to help support you in that way. But again, that's why we do see a lot of people in the hospital with pancreatitis, because it can be a life-threatening disease. And I completely agree, I think alcohol use and overindulging in that is often, at least what I see in my practice, the #1 cause for pancreatitis.
And sometimes we just don't know. Some people are just prone to getting it, just bad luck, unfortunately.
Yeah.
But
It can be difficult to differentiate from gallbladder symptoms too. And so being aware of that, it doesn't always have to be, dead center of your abdomen. It could be off to the right side a little bit too. And so, any of those kind of upper abdominal symptoms probably worth getting evaluated.
Yeah. That was one of the. Is there a doctor on the plane? And I helped with the pancreatitis case. Okay. That was a fun time. Tuberculosis, or commonly referred to as TB, is an infectious disease caused by bacteria that most often affects the lungs. Prairie Doc spoke with Samantha Gervais-Leclerc, a resident physician at the Center for Family Medicine in Sioux Falls, about the disease's severity.
By a small little bacteria called Mycobacterium tuberculosis, so adequately named, and it's just another bacteria that, like I said, primarily targets the respiratory tract into the lungs.
If left untreated, tuberculosis can spread to different organs like the kidneys, spinal cord, the brain, and even the skin.
So most of the time it spreads by people coughing. That will be one of the major symptoms that people will have. And whether it's coughing, sneezing, talking, singing, whatever will put that bacteria into the air via droplets, airborne, could spread it to somebody else. So those droplets kind of stay around in the air for quite some time.
Symptoms of tuberculosis often start moderately, but then can worsen.
At first, some people just might feel fatigued, feel like they have a flu-like, course where you're having cough, runny nose, those sorts of things. But the main thing that people will say is that they have a cough. If it's the active form of tuberculosis, they'll have a cough that can sometimes bring up bloody phlegm almost, or it could be like a greenish yellow color phlegm in some patients that I've seen. If it's in an active phase, you can have some weight loss, you have fevers and chills, you can have night sweats that soak through the blankets at night.
A tuberculosis diagnosis often depends on the person themselves, but doctors often will do a skin test.
Most of the time we do a skin test where they put a little bit of solution underneath the skin, and then we monitor how big that bump gets. If it's big enough, then sometimes people have to have extra testing for that, like a chest x-ray, or they might have to give us a phlegm sample for further testing to make sure they don't have the active form of the disease.
There is also a blood test which can be found in a hospital setting. This form of testing is most common with people who've had the tuberculosis vaccine and will identify if the individual has previously been exposed to the disease.
Some of the common risk factors you can imagine with how it spreads is just being in close contact with somebody with tuberculosis.
When it comes to treating tuberculosis, there are various treatments.
The mainstay of the treatment, though, is antibiotics for quite some time. And there's, depending on if you have the latent form of tuberculosis or the active form, we put a combination of antibiotics together, and patients are usually taking these for upwards of 4 to 12 months at a time. So it's a long duration to try to really get rid of that bacteria in the body to keep it from spreading, like I said, to other organs and such. So I think that the best way to prevent tuberculosis is doing the things that we should be doing, otherwise, especially for respiratory diseases in general, which would be covering our mouth when we're coughing or sneezing, making sure that if, people do feel ill, is trying, and they know that they have tuberculosis, trying to quarantine and trying to stay away from people until their doctor says it's okay for them to kind of socialize again or, be around others.
Gervais Leclerc says anyone at any age can get tuberculosis, but it is most prevalent in young children and the older population.
Some great information there on TB. And, thankfully, I guess in my practice, I don't see hardly any TB. I mean, once in a while there's a latent case, where it's not active. And but I'm assuming in your practice you see it some.
We do see it every once in a while. With the population that we serve, a lot of our new refugees, they would have already been assessed for that. They're not going to be allowed to travel to the U.S. if they've got active tuberculosis. So what we see more of is that latent tuberculosis. So we, will provide the treatment once they're here. But those patients are not infectious. They're not a risk to anybody else. So, but we certainly have had a couple of active TB cases. Quite honestly, it's usually more from our incarcerated population that we see. And so we'll see a higher percentage of cases of TB coming out of prisons or jail, and that's what we've taken care of. Yep.
And in the U.S., we largely don't vaccinate for TB, no. But we treat it.
Yes.
And it's a long treatment, and it's important that we go through and take every single one.
Yeah, it's a pretty closely monitored medication regimen. The State Department of Health would keep very close eyes on that because it is so contagious and it is dangerous. It's just it's not a good illness to have. So yeah.
We've got a lot of great questions here. This person from Parker this caller asks, what are some of the side effects of lisinopril, and is there a natural remedy to replace the medication? Well, what's lisinopril? What are some of the side effects, and what do you recommend?
Lisinopril is a great blood pressure medicine. It's one of our kind of first-line blood pressure medicines. It has indications beyond just blood pressure, though. Patients with chronic heart disease, coronary artery disease, heart failure, they should be on an ACE inhibitor like lisinopril. That's the class that lisinopril falls in. Patients who are diabetic, benefit from being on an ACE inhibitor like lisinopril to help prevent chronic kidney disease. The most common side effect that we hear about, or adverse effect of lisinopril, is a cough. And it's usually kind of a nagging cough. Sometimes it can be confusing because a patient might come in and they've had this cough for a while, or they might think it's an illness, and then we're kind of going through the medical history and medication lists, and there's lisinopril. It's an easy switch, though. We often will switch from a lisinopril ACE inhibitor medication to what's called an ARB, an angiotensin receptor blocker, and so like losartan is an example of that. Those do not have the same adverse effect. So that's generally kind of the one-for-one change that we make. If somebody doesn't have those indications of diabetes or heart disease, for them to be on either an ACE inhibitor or an ARB, then we can switch to whatever blood pressure medicine we want to. So,
yeah. Second part of that question was asking about, natural remedies, and I basically, assuming we're treating blood pressure here, what do you often recommend, especially if they want to avoid medication?
Right. I mean, a lot of this is lifestyle habits, and so, not smoking, that's a big issue for seeing high blood pressure. We'll see that more in our smokers. Alcohol, actually, I think people don't realize just the effect of recurrent or frequent alcohol use and how that can impact your blood pressure. Then of course salt. So what are we taking in our diet? And salt is one of those things that's hidden in everything. And so, it's not just I'm putting some salt on my French fries, but I'm eating, this boxed meal, or even a soda. You drink a soda, there's a lot of sodium in that. Yeah. So I think that's one natural way, is just to really be careful with your diet and limit the amount of sodium that you're taking in.
More whole foods, natural foods, less
fruits and
processed
vegetables.
foods.
Yep, prepare your own food. I think that's a big thing, because then you can control how much salt you're putting in to your meal.
And more exercise.
Exercise, yeah.
Yeah, absolutely. Yep. This person from Facebook asks, I have friends that are using over-the-counter medicine that helps memory. Do those work at all?
I am not aware of any strong evidence that they work. I think Prevagen is one that you hear. There are others. I'm not aware of any strong evidence of that sort.
Yeah, unfortunately, it'd be nice. Mm-hmm.
Right, and I think what I worry about is, people can spend an awful lot of money on some of these over-the-counter supplements without any real proven benefit, and I worry that, people are kind of throwing money away, and, when we talk about memory loss and things, again, exercising, keeping your brain active and engaged, and that can mean reading books or doing crossword puzzles. Just interacting with people is actually a wonderful way to kind of keep that memory robust. Yeah.
Yeah, there's so many things for any disease, diabetes, high blood pressure, obesity. If we can treat those, we can decrease the risk of dementia.
Yes.
Sleep apnea, the list goes on and on. That decreases the risk of dementia if we actively treat it.
Yeah, the other one that I think people make sure that hearing is okay. I think we hear that a lot with our aging population, and struggling with memory loss or just kind of a withdrawal from the things they used to do, but it may be that they just can't hear very well. So, if you have a grandpa or grandma struggling with that, make sure their hearing is good.
Yeah.
This one might have to go back to medical school a little bit here, but we're asking about myasthenia gravis. Remember that one some? So, I think of, just weakness.
Kind of a progressive weakness that might develop. Yep.
And, as family docs, we might identify it and then send them to a neurologist.
Yep.
But maybe
it's pretty rare.
Right,
yeah.
thankfully.
I mean, it is a pretty rare condition, and I do think, people might be concerned if they're getting some vaccines that I might develop myasthenia gravis. It's just so uncommon, and so you kind of have to weigh the risks and benefits of that. And so I would never deter somebody from getting a vaccine because they might develop myasthenia gravis. But this is serious, if there's concern about it, for sure, get evaluated.
Yeah. Absolutely. This caller asked, this man had a double hip replacement and has extreme cold lower limbs. Should he be concerned about the reduction in blood flow? What would you say to that, Carl?
I mean, it's, I wouldn't immediately correlate the two. But if that's a concern, that's a change that has developed, by all means, he should have that evaluated. So peripheral artery disease, decreased blood flow to the foot or to the lower limb, not all that uncommon. I mean, there are things that put people at higher risk: smoking, cardiovascular disease in general, diabetes. Yep. But that can be a serious condition, especially as it progresses. So if that's a concern, then this patient should definitely be seen for it. There's ways to quickly assess the blood flow to the lower limb that, inexpensive and widely accessible, yes. So I'd encourage them to have that evaluated.
Yeah.
And I think you said, the change. I mean, if that is a change for the person, that's more concerning.
Yep.
Maybe you've just always had the cold feet and you don't want to touch your partner in bed or something. I mean, if this is a new thing, that is definitely more concerning.
And given the hip replacement, I would be watching for, signs of a DVT, a clot, and so swelling and redness.
Yep.
We don't necessarily think of, cold,
limb,
but it is something to watch for too.
Yep.
Yeah. Finding the right diet can be challenging. As you age, guidelines begin to change. Registered dietitian Katie Vanderwall spoke to Prairie Doc about the importance of making sure your diet is meeting your needs as you age.
Katie Vanderwall is a registered dietitian at Brookings Health System. With 18 years of experience, she provides guidance for patients of all ages.
As we age, it's very common for our diets to not be as balanced as they once were, mainly because our calorie needs are a lot lower than they used to be. We're not as active, and our muscle mass is decreasing, which is a natural something that happens as we age. Once we hit age 60, we can have a natural reduction of our muscle mass, which then is going to reduce how much energy we burn and how many calories we need. So, as always, we recommend using that plate method to have a really good balanced plate with lean proteins, fresh fruits and vegetables, and then of course some carbohydrates that are whole grains, high in fiber, and really healthy for you.
When it comes to finding the right diet, Vanderwall often tells patients not to overthink.
We have a lot of common conveniences nowadays, right? Fresh fruits and vegetables are always going to be your best, but we also have bags of vegetables, frozen vegetables that you can microwave and have a vegetable in 5 minutes. So it really takes the preparation and the dishes and reduces it to make it a lot easier to be able to get some of those things. You can buy packets of whole grain rice and microwave it in 90 seconds and have whole grain rice. So if you have somebody who is reduced with their cooking skills or challenged in that aspect, you can use easy preparation methods to get more balance in your diet, but you also can work on preparing just smaller batches of food and cook once, but maybe eat 2 or 3 times. Also, feel free to use that freezer to help you.
Those who are aging also have certain unique needs for their diet.
So we just need to remember to incorporate balance and incorporate proteins starting with the beginning of the day to make sure they get enough.
Vanderwall says there is really no set way to tell if an individual is getting all the nutrients they need, but there are some markers to help identify.
For example, if your weight is going up, then we know you're probably overnourishing your body, or maybe there's something else wrong. If you are seeing your doctor and both of you are noticing a really significant decrease in muscle mass, you could have something medical going on, or is your diet not balanced enough? Other ways to know would be if you struggle with constipation or other bowel-related issues, are you not getting enough fiber in your diet?
For older individuals, serving sizes are usually smaller, but it can depend on the individual's age, activity level, and other health factors. She also added, the best way to get the nutrients you need are from whole foods.
There are some elderly people, again, because of their physical abilities to not be able to stand and cook or what have you, that might do more microwave processed foods or protein drinks. it's still better than no nutrition. So there's nothing necessarily wrong with that, but we always want to encourage whole foods, whether it's incorporating higher protein, more balanced yogurts, whether it's incorporating nuts in their diet for snacks instead of cookies and sweets in the afternoon, whether it's incorporating types of oatmeal or grains that are more protein packed. Also incorporating proteins. It doesn't really necessarily take large amounts of meat to be able to help you get the protein that you need at your meals. Even cottage cheese is an excellent snack. Half a cup of cottage cheese can give you 7 grams of protein. Add that with some fruit and you've got 2 different food groups, carbohydrate and protein with fiber. It's a really great option for us snacks.
Some great information. I really appreciate Katie, all of her help with my patients and with stepping up to help us with our dietitian advice and support. And our diet is so important for our overall health. And I don't know, do you guys use dietitians in your practice too?
Yeah, we do. We refer to them. There's certain medical conditions where we definitely want to get them involved. Diabetes, especially a new diagnosis of diabetes, but they can be helpful for any number of conditions.
We have a dietitian in our building. Same, diabetics we like to refer, especially when that early diagnosis comes in, and perhaps just to maintain that support. Patients with congestive heart failure, we will make that referral. And then obviously the one that people think a lot about is just weight loss and trying to support them through that journey. So we would use our dietitian kind of as part of the team.
And that's the thing, I got to admit, I've certainly sent many patients to the dietitian, but sometimes I forget, or sometimes I don't realize that a patient might be willing to meet, and usually they're covered with insurance and with a diagnosis. So, if a person is interested in seeing a dietitian to get more advice, just ask your doctor and they could send you over.
Definitely.
Yeah. Some other great questions here. This is an interesting one. This caller asked, why is the smallpox vaccine ineffective in some individuals? Well, let's take a step back and remember smallpox is one of our first vaccines, right? And very effective. And we eliminated it as far as I know, right?
Yes.
So we're not vaccinating anymore for smallpox.
Not in the U.S., nope.
But in some places
in some places, yes. And certainly, we'll have patients that are perhaps traveling back to their home country, or just people that are taking trips, mission trips, things like that. And depending on where they're going, it may be beneficial for them to get a smallpox vaccine. But, I wasn't vaccinated, you weren't vaccinated, I'm sure. And so to speak to the efficacy of the vaccine, I don't think I could, expertly say anything about that.
But it's probably one of the most effective vaccine campaigns in the history of mankind.
Yes, that and polio.
Right. This caller asks, are there any specific treatments for neuropathy? What do you recommend for neuropathy?
Well, part of it depends on what the cause of the neuropathy is, because there are underlying conditions that can cause neuropathy. So again, diabetes. And so the better a patient's diabetes is being managed, the lower the risk of the progression of that neuropathy. The uncontrolled blood sugars can affect the nerves. They affect the blood vessels, which affect the nerves. So manage it if we can find a specific cause for the neuropathy, managing that underlying cause. There's medications that can be used for the symptoms of neuropathy. And then there's therapy too. If this is advanced neuropathy that's affecting somebody's gait or balance, then physical therapy can be helpful for that sort of situation. But yeah, I would say going back to trying to find out what's the underlying cause and focusing on managing that condition first and foremost.
Yeah, diabetes is certainly a top cause, and arthritis and back problems can be a common cause.
Yeah, exactly. And especially if it's an acute onset of numbness or weakness in the legs most commonly, and there's concern for a back issue, that should get evaluated promptly.
But whether it's some of that or diabetes or a cancer treatment that caused it, and it's probably not going away.
Right.
And it's chronic, how do you prefer to treat it, or what do you do?
Yeah, and I think that's the important piece, is to tell patients is, once this is starting to develop, really what we're going to try and do is help with the symptoms, slow down the progression, which a lot of times is let's get better control of those blood sugars, because diabetic neuropathy is so common. But in terms of medications, I think, my go-to medicine is gabapentin, or Neurontin would be kind of the trade name. Lyrica, I kind of call that the big sister of gabapentin. Little bit newer, more expensive for some patients, depending on their insurance, or if they don't have insurance. Lyrica can still be quite expensive. But those are meds that I would use most frequently for neuropathy. There's a couple old antidepressants that we can use, but they come with a bit more side effect and risk, especially as people age. So probably would lean more towards that gabapentin, Lyrica medication.
Yeah, excellent. This person asks, are there any alternatives to Eliquis, which is a blood thinner, anticoagulant? And they also ask, is it necessary to treat every day when treating ITP? And I guess that's a separate thing, but tell us about Eliquis and alternatives for that.
Yeah, so Eliquis is within a class of blood thinners that for a lot of conditions has replaced warfarin or Coumadin, which is an old blood thinner that's been used for a number of years, and it's still used, but it can be difficult to manage, requires a lot of laboratory monitoring. The benefit of Eliquis and the drugs within that class is that they don't require that sort of monitoring, and they've become quite widely used. We can still run into issues with insurance coverage with those drugs. That's actually quite common. So that is a downside of that class, depending on somebody's insurance coverage. But we use them for managing atrial fibrillation and thinning the blood for that disorder, DVT, blood clot. So they're used for a wide range of conditions.
Yeah. I guess I'd also add, there's some other newer ones too. But they're also going to be expensive.
Xarelto and
too.
Plavix. And
right.
The other thing too, is just something that I've been noticing is for my patients that are struggling with their weight, there are some restrictions in terms of using some of those blood thinners for patients that are obese or morbidly obese. And so kind of going back to the Coumadin and using that medication while the patient is working on some weight loss. But yeah, the newer meds are just so nice in terms of ease of dosing, not having to come in for blood test every week or, at best every month. But they are expensive.
Yeah. Yep. And I do want to add, it is okay to still be on warfarin.
Oh yeah.
And so, I think sometimes a patient goes to the hospital, finds out they have an irregular heart rhythm, atrial fibrillation, and they should be on a blood thinner to help prevent a clot and prevent a stroke. And they're discharged and told, here, take Eliquis. And it costs so much.
Yep.
And I think it's important for them to know, hey, you can be on warfarin. It will mean more visits. But some people find they're reassured by knowing that it's working and that
my blood's not too thin or too thick, and it still works very, very well.
And then it's a lot cheaper.
Yeah.
And oftentimes, once you can find that steady state with the dosing of warfarin, you're kind of set. You don't often have to make many changes after that. So
of course they have to watch what they eat because your food affects it more and stuff. But there are options out there.
Yeah.
Going down to almost a similar thing, this person from Facebook asked about the risk factors for Ozempic. And, I don't know how much Ozempic you get to work with in your patients.
Not a lot. It's expensive. It's very expensive. And even if you have insurance, it's usually for diabetic patients. And so we know that a lot of these injectable meds are doing amazing things for weight loss, but getting coverage for that is very difficult. And we're starting to see people willing to pay cash for these meds. But yeah, there are risks to using those medications, and of course there's no magic bullet to weight loss. And so again, let's talk about your diet, let's talk about your activity level, and make sure that we have those things in place, because the medicine can be a wonderful thing, but somebody that struggled with stomach issues kind of historically, I get very nervous when putting them on Ozempic or some of those other meds. It tends to just really make them nauseated. They do not feel good, and it's the cost of losing some weight because you feel terrible day in and day out. I don't know. I'm not sure it's worth it. But
right. Yeah, it slows the gut and sometimes
too much
paralyzes the gut.
It does. Yeah.
And they might have surgery and not eaten for several days, and there's still food there.
Yeah. Yep. Yeah, there was an article I just read about kind of the percentage of people becoming more malnourished when they're on meds like Ozempic, Wegovy, Mounjaro, just because some do not eat. They're just not hungry. And nice to have the dietitian speaking to that, but I think that's one piece. If somebody is on a medication like that, to make sure they're working with a dietitian to make sure that they're getting in adequate amounts of protein, hydration, because some people lose a very impressive amount of weight, but they're losing a lot of vitamins and minerals in the process.
Very good. This person says from Facebook that I had shingles. When can I get the vaccine, or can I not get it now that I've had shingles, and could it come back worse the next time? Shingles.
Yeah, so the shingles vaccine, Shingrix is the new vaccine, maybe not so new anymore, replaced Zostavax, I believe was the name of the old one. Insurance coverage starts at age 50, I believe, in most cases. So that's kind of the age where we start thinking about shingles vaccine. But just because you've had shingles before doesn't mean that you can't get the vaccine. And if you have had shingles, you can get it again. The shingles virus is the chickenpox virus that lives in your neurons, your nerve roots, and can show up at any point, usually more in times of stress. So the shingles vaccine, even if you've been vaccinated with it, so it's 2 doses, and if you've completed that vaccine series, you can still end up getting a shingles outbreak. Generally, it probably won't be as severe. So it may prevent it altogether, and if it doesn't, probably won't be as severe.
Yeah.
This person from Facebook says, I get high blood pressure every time I go to the doctor, but fine at home. I have surgery coming up. Can they do anything to help keep my blood pressure down going to the hospital prior to surgery?
First, make sure that it truly is low at home. I think that's the importance of having a blood pressure cuff that you're using, bringing that cuff into the clinic to kind of validate, because if you get nervous in the clinic and your blood pressure's high with their machine, it should also be high on your home machine. So it is a real thing, though, that people do get nervous when they're coming into the clinic. Making sure that we're taking blood pressure at an appropriate time in the visit, not right when they've ran in, they're stressed or they're angry because they had to wait in the waiting room for too long, giving them 10 minutes to rest. A properly done blood pressure is important. But if somebody's blood pressure is that high and they're worried that that's going to prevent them from having surgery, I guess I would honestly question maybe they should be on something. I mean, there are meds that you can use to quickly drop a person's blood pressure, but typically, if a surgeon or a medical team knows that this is just white coat syndrome and they're nervous, they're probably going to allow that surgery to happen. And you usually have to have a pre-operative exam with your primary care provider. So if that primary care provider feels like, yeah, this is just nerves, I know that their blood pressure's fine at home, they'll probably say it's okay to have surgery. But yeah.
Excellent. From email, this person says, my 21-year-old grandson just started having heel pain, thinking it may be plantar fasciitis. He's going to try not custom fit orthotics for that condition. He works on his feet all day. If home remedies don't help, should he start with his primary care doctor or podiatrist, or any other suggestions for plantar fasciitis? What is that, Carl? How do you treat it?
Yeah, a common condition. So the plantar fascia is a thick band of tissue that connects from the underside of the heel, your heel bone, to the muscles of the foot, the forefoot. And it can become painful and inflamed. And sometimes we have a cause, like this patient who's working on his feet, maybe on hard floors. That's a common cause. Sometimes it just comes on for no good reason. So it can be kind of frustrating in that regard. It sounds like they're on the right track, though. So inserts, orthotic inserts, whether they're custom ones, which can be quite expensive, or a good quality off-the-shelf one. There's ones that you can buy off the shelf for maybe in the $20 to $40 range that can actually mold to your foot, and in some ways kind of become a less expensive version of a custom. That's a good place to start. Supportive footwear. We tell patients to wear footwear indoors too. So having like a pair of in-house shoes that you put on and trying not to walk barefoot, because that's going to aggravate it more.
And not just flip-flops.
Yeah, correct.
Something with some good support.
Yep, correct,
Yep.
correct. Just another pair of shoes that you put on inside. So those are good places to start. If they're still having issues, primary care doc is a good next step. A podiatrist would be happy to see this condition as well.
Yeah, I think of the Strasbourg sock, that sock that helps stretch that foot up, and classically you're first getting up in the morning and that hurts. It affects Twins baseball players and others alike.
Baseball players.
Yeah. Well, we don't have a whole lot of left, but how long can you take iron pills for? This caller asked. This 90-year-old woman takes iron pills every day. Is that okay?
I would say that's fine. If this woman is feeling well and not struggling, iron can be a constipating medication. And sadly, as people get older, sometimes those bowel habits become more of a challenge. But, if she's been taking that every day and is having regular bowel movements and feels good on the iron, I would say keep taking the iron. There's no reason not to. Yeah.
And you can always ask your doctor, too.
Yeah.
You guys have been great. Good job. Thank you so much for joining us.
Thanks for having us.
Our winner is Lyle. A book will be sent to you shortly. We'll be back after this.
On Call with the Prairie Doc has been a leading source of health education for 22 seasons. Join us this season as we continue to provide health education based on science, built on trust. Follow us on Facebook, Instagram, YouTube, and TikTok to access the entire Prairie Doc library.
A big thank you to our guests, Dr. Rasmussen and Dr. Tinguely, for volunteering their time to help us learn more about any medical issue our viewers have. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok for now, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
A headache is a pain in your head or face that's often described as a pressure that's throbbing, constant, sharp, or dull. Sources of headaches and management of pain. Next time on Call with the Prairie Doc.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy. Hello, life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,